Okay. Good afternoon, everyone, and thank you for coming. My name is Paul Sutton. I'm one of the policy researchers here at CTAC, and welcome to our Policy Roundtable webinar reviewing the current draft form of our new Treatment Access Bill of Rights. And so, for those of you who don't know so much about CTAC, or even those of you who do, CTAC is Canada's national civil society organization addressing access to treatment, care, and support for people living with HIV and hepatitis C. CTAC meaningfully engages community members, service providers, policymakers, and researchers to identify, develop, and implement policy and program solutions. And one of the interventions that we're trying to make today is in the form of a Treatment Access Bill of Rights, which is the reflection of a longer piece of work that's been undertaken at CTAC since late last year. The Treatment Access Bill of Rights was an area to move on that was identified at a joint meeting of our Board of Directors and Council last November. And from there, some really exciting things have happened. After a number of us on staff here at CTAC, led by me, had an opportunity to review what currently exists in terms of the patient rights literature, as well as the patient rights literature specifically for HIV and for people living with HIV in Canada, we moved into a really amazing session that we held at the Canadian Association for HIV Research Conference in Vancouver this April, where a group of people living with HIV, as well as service providers, other civil society leaders, members from industry, and other community partners all came together in order to do a really creative brainstorming and generation session, the results of which you see reflected in the draft Treatment Access Bill of Rights that I circulated to you when you registered for this webinar, as well as recirculated to you in the reminder email from today. So what we're attempting to do today is to go, is four things. One is to go over the patient's rights literature in the health system writ large, and as well as what that looks like for people living with HIV in Canada, which will give us a little bit of our backgrounder in terms of what led us here today. After that, what I'm going to do is go over the key areas addressed in the Treatment Access Bill of Rights draft that's been identified to you. And then really it becomes up to you. So we'll open it up for a discussion here on the webinar that I can moderate using that raise hand guy that we all practiced working with a little bit earlier. So it's an opportunity to go over these pieces. And so I hope that we'll be able to have a really fulsome discussion over each area that's included in the Treatment Access Bill of Rights in its draft form. And then there will be a second opportunity for you to have feedback. For those of you who have participated in these sessions before, you know that there's always an opportunity to go onto a survey collection mechanism that I'll give you the link for at the end of the webinar, as well as in an email for follow-up so that you can fill it out over the weekend. And by the end of the weekend, we hope that you'll be able to give us the opportunity to give us your thoughts on what might be tweaked or what might be improved, or just generally what you think about the draft Treatment Access Bill of Rights. So that's our agenda for today. And if nobody has any questions about the agenda, you can feel free to raise your hand right now if you do. But seeing none, I'm going to launch into a little bit of a review of patient rights in Canada, and specifically how this works and what this means for people living with HIV, and why we decided to undertake a Treatment Access Bill of Rights today. So the first and foremost thing, and the biggest reason why we were interested at CTAC in developing a Treatment Access Bill of Rights is primarily because of our mission as an organization that's interested in enabling and maximizing access to treatment for all people living with HIV, and now as we've expanded our mandate for people living with hepatitis C in Canada as well. But on the HIV side of things, in Canada, where we have public health coverage, although not public pharma coverage in all sections of the country, which is something that I'm going to talk about a little bit more in a minute, we see that 30 years into the HIV epidemic, numbers that we shouldn't exactly be comfortable with around the number of people who are accessing treatment. So this data that you see on this particular slide comes from a study that was published by Robert Hogg and others from the BC Centre for Excellence, and this was published in November of last year, November 2012. And for the first time, Hogg and his colleagues at the Center for Excellence came up with a way of modeling just the extent to which treatment is accessible and available across Canada. And what was found was some not necessarily encouraging results. So what was found was that of all people living with HIV in British Columbia, 45% were accessing treatment, whereas only a little over 36% in Quebec and a little over 32% in Ontario were accessing treatment. Now, one of the important things to keep in mind is that this number, if you were to think of the whole 100% set of people who are to be included and understood in this graph, this does take into account the 26 to 30% of people living with HIV who are estimated to not yet have been diagnosed. But if one then comes to think about it, that leaves, in the case of British Columbia, a good 25% of people in Quebec and Ontario, 35 to 40% of people living with HIV who have been diagnosed who aren't accessing treatment. And we all know, and we'll get into this again a little bit further, that there's lots of reasons for not accessing treatment yet. While a lot of the dialogues on when to start treatment are changing based on some new data and some new evidence that's coming forward, it's sufficient to say that, especially in Quebec and Ontario, 35 to 40% of people living with HIV diagnosed and not accessing treatment reflects barriers as opposed to just a lack of medical indication to yet start accessing treatment. And so this is really the jump-off point that I hope to start with today, that there's a need to enable and increase access to treatment, and that we do know from an increasing amount of data that people living with HIV who are particularly marginalized, especially people who are incarcerated, homeless or underhoused, substance involved, or newcomers to Canada, experience expanded barriers to treatment. And so one of the things that we're asking to think about today is how could rights interventions hopefully provide us a bit of a platform to start talking about things that need to be done in order to be able to reduce these barriers. So why a treatment access bill of rights? The starting place that we're asserting from is that all people living with HIV deserve access to treatment, and deserve access to treatment based on these four, and I think pretty self-evident guidelines. People living with HIV deserve access to treatment when ready to start treatment, treatment that does not result in an increased financial burden for people living with HIV, treatment that has few side effects or adverse events, and access to treatment that isn't prevented due to experiences of marginalization. And these key areas were very much taken up by the people that we worked with in Vancouver to really generate and think through many of these and many of the treatment access rights that you've seen in draft today, and really are a kind of key cornerstone piece to start from. Now, what I first want to talk a little bit about is the right to health. And why I want to talk about this is the right to health is an area that really underpins a lot of the Canadian health system and a lot of the Canadian health systems, or the Canadian government's obligations under various international charters to provide health care to all of us as citizens. And the right to health, basically generally described, or generally defined, describes relationships between people and the systems or institutions through which they access medical care. And there's a list here: hospitals, family doctors, prescription drug plans, rehabilitation services, sexual reproductive health clinics. These are just a few, and the list could go on and on and on. So it's all about all of us within a health system accessing each of these services. And usually the right to health and in particular rules and regulations that identify a particular person's access to the right to health has to do with payment plans, with various clinical guidelines, such as a point at which, if we're thinking about treatment, the point at which a person is showing a particular medical symptom. So in some areas of the country, a CD4 cell count of 500 or less, for example, before treatment is recommended, as well as codes of conduct between people living with HIV and their physician. Now, to build on this a little bit, the right to health, all of our health rights under the Canadian government and all governments really, can be spelled out as in terms of individual or collective rights. And so the rights that we have to health, which I'm going to enumerate on the next slide in Canada, can be understood as collective rights. rights that are granted to all Canadians based on citizenship. And there's another way then to think, and so that's reflected in terms of the way that you, me, anybody else can walk into a hospital in Canada, and it's expected, or we should be able to expect, a certain level of service or a certain level of care that's regulated at the level of Health Canada and by legislation called the Canada Health Act, which I'll talk about in a second. What doesn't get covered in this as much is the realm of individual rights. The good practices that every single one of us, whether we're living with HIV or not, whether we're experiencing whatever health condition, can expect or demand in our one-on-one engagements with institutions. When we talk about patient rights, we're most often talking about individual rights, and as I'm going to explain in a second, there are much less individual rights encoded in the Canadian health system. A lot of collective rights, and one of the things that we can see, especially as I explain on the next slide about the Canada Health Act, is that I think that we all have reason to believe, especially when we're talking about working with or being in positions where we're marginalized, that we have reason to believe that we may need a little more than just a series of collective rights in order to ensure that we all have the best access to health. So what I want to talk about next is the Canada Health Act, which is the major piece of federal legislation that governs health in Canada, and governs health in Canada because it governs the process by which and the standards that provinces can use the approximately 20% of all health expenditures that are granted to them by the federal government. So as a little bit of Health in Canada 101, which is very much a 101 because I don't want to necessarily dive into this particular piece. But Canada has a bit of a strange way of funding health services. And it basically comes down to this, that provinces and territories are responsible for the governance and the delivery of health care in Canada. That's a provincial domain. But a significant aspect of health services in Canada are funded by the federal government. So it's a strange and tenuous relationship between the federal government and the provinces, where the federal government holds a number of the purse strings and then also functions as a bit of a watchdog in terms of how or the phrase is intended to function as a bit of a watchdog in terms of how health services are maintained or produced in provincial government. The Canada Health Act mandates that all of the services that it funds correspond to each of these collective rights areas: public administration, comprehensiveness, universality, portability, and accessibility. And I'm going to just spend a couple of seconds on each. So the Canada Health Act demands that provinces and territories administer health services that are public, that are delivered on a not-for-profit basis, and it's under this rule that health services in Canada cannot be profit-seeking. It also demands that health services are comprehensive. So it sets the scope of publicly funded health services and demands that that health services, including hospital care, physician services, and dental care when performed in a hospital, must be public, must be delivered in this not-for-profit way. Demands that health services in provinces and territories must be universal, that provinces and territories can't say some people in their province or territory can receive health services but not others. Also says that health services must be portable, and so that people who move between provinces or territories must be given the health services paid for by their former province or territory of residence as they're moving between the country, and this is for a period of 3 months. And then also says that these services must be accessible, which demands that all residents have a right to a consistent standard of care, whether you live in Toronto or whether you live in North Bay, whether you live in Vancouver, or whether you live in Prince George, right? And so as I've been describing each of these things, I just want us to keep in mind that when I was giving a little bit of warning that maybe these collective rights aren't enough to govern health services in Canada, we can probably all think of some ways in which each of these collective rights or collective regulations around public health care are being eroded a little bit, right? We know that there's an emergence of third-party public-private partnership clinics in order to mitigate mitigate costs or health demands on the health system. So moving some sort of areas like orthopedic rehabilitation services, for example, out of hospitals and into private clinics. So that we're seeing a little bit of an erosion on that. Certainly all of us who've worked with people living with HIV and hepatitis C knows that this comprehensiveness test, as well as the accessibility test for anybody who's worked outside of a major center, right, is not always met. That we cannot expect, or that we don't often see, exactly the same level of services in all hospitals across the country, for example, or in all clinics across the country. And certainly anybody who's had an experience moving from one province to another knows that while the portability rule may take place in theory, especially if you're a person living with HIV or hepatitis C and you're trying to maintain catastrophic drug coverage or catastrophic drug care between provinces while moving, that this is an incredible, incredible headache. And oftentimes, almost all the time actually, when we see people moving between provinces, we see treatment delays and treatment access barriers, or people having to go back to their province of origin in order to be able to get additional health services or treatment. And that this isn't necessarily the way we want to go. And so what I think that we're trying to do today is to talk about some ways in which maybe an individual rights framework could allow us as an HIV and hepatitis C sector, although speaking mostly about HIV today, that we as an HIV sector can demand better services and better policy based on the specific barriers that we see providing services all the time. So, patient rights in Canada, and here I'm talking specifically about individual patient rights. Patient rights in Canada really only exist in Quebec. I'm going to talk about some other failed legislative attempts in English Canada, but in Quebec, Quebec in their health law has a series of individual patient rights that people accessing the health system can expect. People in Quebec accessing the health system can expect and have the right, have an enshrined right to being informed of what medical services are available, to receive continuous and personalized health services appropriate to where they are in their place and time and in terms of their health conditions, to choose the health practitioner that they'll receive services from, to always receive emergency care when needed, to be informed of any and all health conditions prior to consenting care, and to participate in decisions regarding care. And these are enshrined in the health law. Now, for the rest of us, we're not so lucky. There was an attempt at a federal patient rights legislation in 2001 that failed. And some of the highlights of these failed attempts at patients' rights legislation is that the federal law would have mandated access to treatment and patient-centered treatment decision-making, which we can imagine that we would have a bit of a different foothold for those of us who do treatment access work if this was actually a matter of federal law and could be applied through the federal systems and across through provinces. We'd be talking about a bit of a different scenario. In Ontario in 1999, during the Harris years, the opposition put forth attempted legislation that would have required doctors to respect human rights, freedom from harassment, to protect patients from give them freedom from harassment, individual dignity, and respect for cultural customs. Although that particular failed. And one of the things that's really particularly interesting is that, and this actually does exist, not in terms of the level of legislation, but it does exist as a code of conduct in Nova Scotia that as of 2000, there's a document, a reference document for the Nova Scotia health system that identifies that for better health outcomes to be achieved for all people, that social level change must occur to eradicate intersectoral and other barriers to ensure better health and better health care, and specifically enumerates the social determinants of health. And so these are really interesting moves that look at how to be able to maximize individual health rights within systems, although didn't get enshrined at the level of legislation at the federal government or in Ontario or in Nova Scotia. There's a couple of other examples that are explained in the reference document in the discussion paper around a treatment access bill of rights that I emailed each of you this morning. If you want to take a look, and you can ask me anytime by email after this webinar. Now let's talk about some HIV specific interventions. I think from what I've been talking about, everybody can see the relevance of addressing individual rights, especially when it comes to protecting the health rights of people living with HIV for a lot of reasons, in terms of treatment, in terms of confidentiality, in terms of autonomy. And to this end, two civil society organizations in Canada, CAS, the Canadian AIDS Society in 2009, and COCSIDA in Quebec in 2012, delivered rights documents about the rights and, in some cases, responsibilities associated with good health outcomes for people living with HIV. And so here are some of the things that are identified in the CAS, that are common to the CAS and COCSIDA documents, identifying that people living with HIV have a right to care that's free from stigma and discrimination, to up-to-date current treatment information, including complementary and alternative medicine, a right to shared decision-making on treatment and care, to the confidentiality of serostatus and medical records, to honoring a living will, to professional respectful treatment, and to assistance to overcome linguistic, cultural, or other physical barriers. Now, one of the things, there are a couple of differences between these two documents. In the CAS Bill of Rights, there is an identification of responsibilities that are relegated to the doctor-patient relationship, including the responsibility of people living with HIV to ask questions, especially regarding pain management, to provide complete information, and to take responsibility on an agreed-upon treatment plan. And the COCSIDA declaration also kind of goes a little bit outside of the traditional clinician-provider environment to talk about how people living with HIV are responsible to promote active civic participation, solidarity with other people living with HIV in societies, and anyone touched by discrimination, and to participate in the ongoing fight against prejudice, stigma, trivialization, rights violations, and discrimination. So why, for example, then, is CTAC getting into the fray about patient rights for people living with HIV? And one of the things that I wanted to talk about is things about treatment that are a little bit different. And I think that this will be old hat for a lot of people on the call. But we know that there's some specific barriers and specific vulnerabilities that our organization exists to fight against around access to treatment. So I talked right at the very beginning of and gave maybe the paramount reason, which is that 30 years into the epidemic, not enough people have access to HIV treatment. And I think that that's a really important thing to point out and to continue to harp on until we see those rates increase. One of the things also that we know is that HIV treatments need to be improved, that still, and obviously in comparison to the early days in the HIV epidemic, the possibility of having once daily medications or a combination of relatively easy to take medications for people living with HIV that are for people who have access to treatment most often suppress viral load to undetectable levels, that this is a great thing, but the road's not over yet in terms of where we are in terms of HIV treatment technology, the possibility of reducing to weekly or monthly dosing, and also the drastic need to reduce adverse events and side effects, especially in terms of neuropathy and kidney toxicities, for people who are living with HIV who are going to be on antiretroviral therapy for a long time, that there's a need for technological improvement. We know that not all therapies are available across Canada, so this piece around comprehensiveness and accessibility outlined in the Canada Health Act certainly does not apply to the way that we see catastrophic drug coverage covered either federally or provincially or territorially across Canada, depending on which plan a person accesses. We know that, and also that access to treatment is certainly better off for the very few people, although the people living with HIV who do have access to private insurance. We know that HIV care coverage in a broader part is not comprehensive, and that a lot of people incur additional costs and responsibilities to pay the costs associated with treating the treatment of being able to address adverse events, and that this can represent a substantial financial toll, especially for people who are economically marginalized. We know that social vulnerability correlates with poorer treatment access, and so something needs to be done about the conditions, and We need policy change to fix the conditions by which incarcerated people, by which people who are homeless or underhoused, by which people who use drugs and by which people who are newcomers to Canada, and by which Indigenous people face poor treatment access outcomes or poor treatment access rates. We need to address this question that new HIV medications may become increasingly limited, that what's in the pipeline may not become publicly available in the days that where HIV medications that we currently use are coming off patent, and when public pharmaceutical plans are trying to clamp down on expenses. This is something that I'm not going to address so much here. I can explain in the question period, certainly, as something that we will be addressing much more fulsomely at our National Treatment Access Conference, September 16th and 17th, for those of you who will be able to attend. We know that treatment decision-making autonomy must be protected for people living with HIV, and that we hear ongoing reports that this is especially important in some areas and in some ways, and to spell this out, as the push to recognize the ongoing prevention benefits associated with treatment, or otherwise known as treatment as prevention, become more and more scaled up on the policy agenda. And that we also know, really importantly, that additional ongoing support is required for HIV cure research and development. It is a rarity that an entire group of people, such as people living with HIV, have been expected to live so long taking daily treatment without there being a similar obligation and a similar demand, a similar expectation from policymakers and scientists to push for cure. And that's something that's important to talk about too. Okay, so as I said, after we did the research, and the research that I just kind of reflected here, we moved into a consultation session, a workshop that we held at the CAR conference in 2012 in Vancouver. And we had about 35 people in attendance. I think some of the folks on the webinar were actually in attendance today, or attendance on that day, so thank you for joining to see where things have come from that. And we did two things in order to be able to prepare for this piece. The first one is that we granted everybody who registered for the session access to a survey to ask what their sort of banner concerns about treatment access and what might be able to be put into a Bill of Rights might be. And then from that, we developed 5 sort of discussion sessions or discussion areas and assigned them to different tables with facilitators and asked people to self-select what they wanted to talk about, and we had that sort of open space activity for an hour and a half. And between the sort of pre-questionnaire and the activity, these were the key areas that were discussed in that session. A need for equitable, up-to-date treatments, a need for equitable access across the country, a need to end stigma in care, a need for culturally competent care, including effective link to care and retaining care strategies, as well as the protection of the right to choose when to start treatment. There's a little bit more here on the second slide. A need for universal drug coverage, to not talk about the opt-in and inequities that are produced by various catastrophic drug plans across the country, that if you live in New Brunswick or you live in Ontario or you live in the Northwest Territories, that you should be able to access the same treatment no matter where you live. That there's a need for better treatments to reduce adverse events as a key policy priority. That there's a need for increased and enhanced treatment access and support for people who are homeless, people who are incarcerated, et cetera, as well as full access to a continuum of care. And this is again another piece about treating the treatment, as well as accessing treatment as a whole individual, to have fully subsidized mental health services for all people, especially people living with HIV, as well as income equality or income equity services, so that people living with HIV are not living in poverty just in order to be able to access treatment or at all. And so that brings us to the draft version of the Treatment Access Bill of Rights that was given to each of you in advance of this session. And so just in case there's anyone who didn't get an opportunity to read it beforehand or take a look and make notes beforehand, what I'm going to do is I'm going to, as quickly as I can, read it out. And then what I propose that we do is that we have a discussion based on each of the 5 areas, these themes that are addressed here on the slide, that are talked about in the Treatment Access Bill of Rights. And so I just want to start then by going over what's said here. So in the Treatment Access Bill of Rights, the main preamble is that all Canadians living with HIV deserve access to treatment regardless of where they live. Treatment must be universally accessible and must maximally enrich quality of life. And so our statement here is that all Canadians living with HIV deserve the right to, and under the chapter Affordability and Accessibility, the right to free universal access to treatment, regardless of income, background, or area of residence. The right to continuous treatment, regardless of area of residence. The delays in getting access to drug plans when moving between provinces and territories, as well as limiting access to 1 month's supply of treatment at a time, inhibits the charter right to uninhibited mobility within Canada for people living with HIV. And then the right to initiate antiretroviral treatment when prepared and without delay, and that hard initiation decisions ought to be made by people living with HIV without outside interference from physicians, policymakers, or community members. Under the chapter Tolerability and Quality of Life, the right to access the best treatment available as determined in conjunction with physicians. And that in order to ensure new treatments fulfill areas of unmet need, people living with HIV must be included at every stage of drug development and availability, from early identification of new molecules that reduce adverse events, to clinical trial design, to uptake in the health system as a part of regular prescription and coverage practices. That treatment options that maximize adherence issues and make it, or the right to rather, treatment options that minimize adherence issues and make it as easy as possible to live with HIV over the long term, including less frequent dosing. The right to address and or treat intersecting conditions, including but not limited to the right to access rehabilitation services, mental health care, safe housing, food security supports, and income support. Under the chapter Continuum of Health Services, understand on an ongoing basis how HIV is affecting overall health. This is, I think, particularly important in the current context. In addition to best practice monitoring of internal organ functioning, especially liver, kidney, heart, and brain health, people living with HIV require on-demand assessment of CD4 and viral load, especially in our current context where viral load status has been enshrined as a prosecutorial threshold in HIV criminalization. The right to access solid organ transplantation when medically required. In order to satisfy the increased need for organ transplants amongst people living with HIV, a system guiding transplantation between people living with HIV must be instituted as a key health policy priority and to increase the organ supply. And the right to robust and culturally competent health system capable of meeting individual needs. And to note that a range of health services must recognize varied realities of people living with HIV, offering people the option of managing their HIV as privately as possible and or offering access to support services including group interventions, assistance navigating the social safety net, and outreach support to maximize continuous access and adherence to treatment. Moving forward, under the chapter Full Citizenship for People Living with HIV, the right to true equality in Canada with insistence of public education and community initiatives that dispel HIV-related stigmas. And go on to say, all health systems must ensure they are competent to address the lived reality of HIV for all people accessing services. HIV prevention messaging must be developed with people living with HIV to ensure educational materials do not reinforce stigma. The right to autonomy for Indigenous peoples without outside interference. And that recognizing that self-determination increases positive health outcomes and is a foundational step to addressing the overrepresentation of Indigenous peoples in the Canadian HIV epidemic, and that policy initiatives must support the decolonization of Indigenous peoples. The right to a society without gender violence, racism, homophobia, and transphobia, and that to maximize health outcomes for people living with HIV, substance use and commercial sex must be decriminalized, supporting sustainable social supports within these populations. And finally, under the chapter Cure, the right to research agendas that are determined to deliver an HIV cure, and that, as I said before, too long have people living with HIV been expected to access and adhere to currently available treatment regimens without sufficient attention to viable cure options in the pipeline. Improvements in antiretroviral therapies must be met with increasingly rigorous explorations into a cure once and for all. And so from this, I'd ask us to move then into a discussion. I think probably the smartest idea or the easiest way to facilitate this piece is to go chapter by chapter. And so I'm going to turn it over to you and ask you to raise up your hand if you have a question, a comment, a change that you might want to try workshopping around, first under the chapter Affordability and Accessibility of Treatment. And so feel free to put up your hands, and then I will ask you to press #6 to open your line. So the first hand that I have is from Walter. Walter, can you press #6 and share with us what you want to say? Walter,
Okay.
are you there?
Yes, I am.
Okay, good. Hi.
Hi. My question or comment has to do with the very first line, which all Canadians living with HIV deserve the right to. When you look at the Charter of Rights and Freedoms and look at the Canada Health Act, they actually concern people who are residents of Canada rather than Canadian citizens. And in places it'll talk about the individuals, people, they use different terms, but and sometimes talk about citizens. I'm just thinking that the first line should be all people resident in Canada living with HIV.
Totally. I agree with you, and thank you for pointing that out. And I think, especially in terms of focusing on the massive unmet need for newcomers to Canada, those with and without status, I think that that's a really important piece to point out.
Yeah. And another detail is that sometimes people who are incarcerated or members of the armed forces are not considered to have the same rights as permanent residents of a province. So it's just that I think being all-inclusive addresses that as well.
Totally. And actually that may be an important piece to point out in this affordability and accessibility section under the continuous treatment regardless of area of residence, to specifically name incarcerated people and people in the armed forces or working outside of Canada or not sort of in the traditional provincial healthcare system. So I think a note there might be really good too. Anything else on that particular piece, Walter?
No.
Okay, thanks. And if you wish, then you can press #6 to mute your line until your next comment, and I hope that there will be another one too. Does anybody else have a piece that they'd like to talk about, either in terms of the general preamble or the affordability and accessibility section? Okay. I have one from Christian. So Christian, if you'd like to press #6, looking forward to hearing what you have to say.
Can you hear me?
Yes.
Hey, Paul. Hey, everyone. Yeah, I kind of reviewed the document, and then I guess there was this initial thought. I know this Treatment Access Bill of Rights is specifically for people living with HIV, right? About HIV access. But then just knowing the work that CTAC does, I don't know if, do you have plans to kind of draft one for people living with viral hepatitis? Or I know some of the needs are different, some of the issues are different, but then it just kind of stood out for me. And then as I read more of the document, I realized this is really specific for HIV or PHAs, right? So you might want to, I don't know if you want to just make it a little more explicit that this is actually just for HIV treatment access. Mm-hmm. And I think I made some notes. I think Walter made the comment about people's immigration status already. But let me see. under the tolerability and quality of life, I thought maybe if we can add something about the long-term health side effects from treatment or something like that, that might be important. Because I'm not really sure how well we are tracking about the long-term health side effects from all these treatments per se.
So in terms of more research and monitoring, then, Christian.
Well, yeah. I mean, I think that's crucial, right? And then you have these drugs that get approved, but like, what are the long-term health side effects, right?
Post-marketing surveillance, for sure. Yeah, which we talked about in the last policy roundtable as well. I think.
Yeah. So, and then under the cure, I think just the last note. I think I was in Montreal. You were in Montreal too, like earlier this last month, and then I think from that discussion, I guess, while we are obviously for the cure, but I think I heard a lot of concerns about people wanting that if we invest in finding technology to find a cure, we not lose sight on the current needs of those who require treatment and services as well. So I don't know if that needs to be like made a little more explicit, but I think that was kind of what I got the gist out from, and I just want to convey that. Sure. That's all I have to say.
That's great, Christian. Thanks. And specifically, I think that's why we, although in terms of the final draft of this, and if anybody has some idea around the languaging around this, please feel free to bring it up now, or please feel free to bring it up sort of confidentially in the feedback survey that I'll give you access to at the end of this webinar. But I think the specific idea that improvements in antiretroviral therapies must be met, right? That this has to be something that goes hand in hand, and that it's insufficient. Although, I mean, I could go into we should actually have some concerns around the state of the antiretroviral pipeline, although that might be a conversation for another webinar.
Right.
That this is something that we have to be concerned about. That attention's not going to go off potentially improving the standard of care in terms of antiretroviral therapy, especially around, and I think that this is particularly relevant around increasing or decreasing dosing frequency. And this is actually something that's really been kind of fallen off, although it's getting back on the agenda, this idea that daily dosing is actually not great if we could have weekly or monthly dosing as well. But I think that's, and it was interesting. I ran a sort of very informal Facebook poll. We posted a story about less frequent dosing on the CTAC Facebook page, and it was responded to with I think more vigor than any Facebook posting that we've ever made, in the sense that, like, yes, of course, this is something that's desired not by everybody, but by a massive number of people living with HIV. So this is a really important thing. The other thing, Christian, that I wanted to address, because I referenced at the beginning of the presentation that obviously CTAC's undertaken hepatitis C into its mandate more formally, expanding out of just our co-infection work. Does everybody still hear me? Yes? Good. Sorry, I lost my...
I can hear you.
Okay, good. I lost my network connection for a second, but then I was confused whether we're using the phone, so it's fine. So as we've moved to incorporate this hepatitis C more thoroughly into our mandate, this is very much, as Christian pointed out, an HIV document. And so one of the things that I hope that we'll be able to undertake over the next year and a half is to be able to take this document as a guide, but really get together a group of people living with hepatitis C or have cleared hepatitis C and achieved an SVR from treatment, to talk about what applies in terms of hepatitis C and what doesn't, so that we can maybe come up either with a companion document for people living with hepatitis C, or use this as an opportunity to clearly, as well as respectfully and responsibly, map out what bridges between both patient populations and what doesn't. Because I think that there's a lot of things in common, but there's also key differences between people living with HIV and people living with hepatitis C that need to be respected. So I think that that's my commentary on where to go from this. So I don't think that, certainly we're not planning, and I'm very committed to not seeing an incorporation of hepatitis C across our organization be done badly, in the sense that hepatitis C just gets combed in as though there are no crucial differences or needs. So that's a key thing. Does anybody else have a question or comment or something that they'd like to build off of what we've been talking on? I mean, I think that we can probably say on any of the points here in the Bill of Rights. Okay, I have a raised hand from Enrico. So Enrico, if you could press #6 to unmute your line.
Hi, Paul and everyone. First of all, thank you for all the work you've done on this. It's a great document. I have just actually one comment around the tolerability and quality of life, because I know that CTAC is doing a lot of stuff on the informing part of access to treatments, and there's not anything there around the informing, around the patient input part, particularly around when it talks about, you do talk about, you know, that we should be in part with the clinical trial design and then to the uptake in the healthcare system, but I'm not sure if the uptake in the healthcare system means the patient input part.
You know, it's interesting that you point that out, because I missed a step in terms of, or rather we missed it. This was more than just me putting the draft of this document together. But I think that that's an important piece to be specific about, Enrico, to lose that kind of key.
You know that, yeah.
Yeah, to lose that.
I know that CTAC's doing a lot of work on the informing, the access part, so I think that that's something that should be in the patient rights. Mm-hmm. Mm-hmm. Yeah. And patient engagement, you know, like around the tolerability and the quality of life, the importance of getting patients to talk about that during the approval process.
Mm-hmm. Mm-hmm. For sure. Thanks. Any other points that you'd like to raise, Enrico?
No, thank you.
Okay, great. Thanks. Does anybody else have another thing that they'd like to build on in terms of that, or another question or comment on any of the pieces here in the Bill of Rights? Just feel free to raise your hand. Oh, I've got another one from Walter. So Walter, if you'd like to unmute your line with #6.
Can you hear me?
Yes.
Okay, my question was on the autonomy for Indigenous peoples without outside interference. Does this come from Indigenous people?
It did. There were some Indigenous peoples who were involved, or some people who are identifying as Indigenous in the drafting session that we held at CAR, as an important component of recognizing some specific ways in which colonization functions differently than other forms of marginalization and oppression in Canadian society, as well as a way of specifically identifying the need to come up with specific approaches driven by Indigenous peoples in order to be able to address disproportionate HIV rates within communities, especially in terms of the increase.
I think that's very important, but the last part, policy initiatives must support the decolonization of Indigenous peoples. There is certainly a strong force against promoting assimilation, and I'm just afraid that might be interpreted as promoting assimilation.
You know, it was interesting that upon reading it again, I think that, yeah, that language certainly can be improved to remove any kind of assimilation, any sort of assimilationist rhetoric. because it's in the ordering of the language, isn't it? Right? It's
Yes.
that policy remains post decolonization, right? It happens is the way that this sentence reads, which was certainly not the intention. So that's something that I can work on as well, too, leading into that.
Thank you.
I was curious, actually, if somebody was going to point that out. So thank you for taking a look at that. So one of the things that I can do then is to commit to reworking that particular piece of language.
Okay.
Any other questions or comments or general discussion as well? Okay. Well, with this, and feel free to put your hand up just as I'm closing here if you do have something else that you'd like to contribute. But I want to very quickly talk about sort of what's next in this document. So the feedback, and please hold on for a minute because I am going to give you the link to provide feedback on this piece. The feedback that you provided today verbally will go into a revision of this document, as well as anything that you provide over the internet today will go into a revision of the document as well. And just the other thing too is if you've given feedback here, please do go into the SurveyMonkey survey because it'll give you an opportunity. There's basically two surveys. One survey is to provide your feedback, which is totally anonymous, and then it provides you a link option at the end of that survey to another survey, which gives you the opportunity to record your name, so that if you want to be included in the list of reviewers or contributors in this policy roundtable, it's important for us to be able to recognize everybody for their work and contributions that they make to this process. So I think that's an important piece. This then will be a final version will be presented at our Treatment Access Conference on September 16th and 17th, so in a little less than 2 weeks here. So that will be presented and made available more publicly. There's a couple of steps that we've committed to with this document at CTAC a little bit further. The first is that there's going to be requests for signatures from a petition at the Treatment Access Conference, as well as electronically from people who are not able to attend, and that petition will be delivered to legislators in the federal government on World AIDS Day. This is sort of a series of requests and demands that we want to put forward to our legislators to address the unique needs and identify and address the unique needs related to treatment and to push or support, or at the very least generate some attention around where legislative action might be able to assist in this matter. So I think that that's an important component. I think also that this Treatment Access Bill of Rights is particularly on the HIV side of our work, really sets out a series of values and a series of things that we internally, as well as in working and generating partnerships with other individuals and organizations, can really say, this is what we stand for, and that, looking at this document, I really see how it does reflect to the way that we plan program and policy interventions. And so I think that leading into the future, after this sort of initial move to take it and present it to legislators, that you'll also see it as a touchstone, as a guiding document to the kind of work that we're undertaking and committing to do with and on behalf of our membership. So those are the things that I think that you can expect to be seeing moving forward on this document, especially as it has to do with informing ongoing dialogue around access to and the provision of universal pharmacare coverage for all Canadians, or all residents of Canada, including people living with HIV and hepatitis C. That's a key concern that we continue to be addressing across our organization. So what I'd like to do is just say some thank yous, certainly to each of you for attending today, as well as to all the participants from our April 11th, special ancillary session at the CAR conference, to the presenters and facilitators in that session, including Maureen Owino, Warren Michelow, Daniel Grace, Tim Rogers, and Richard Elliott, to the CAR organizing committee, as well as to all of CTAC's members, partners, board of directors, and council. To learn more and to follow as we do this work, please always feel free to visit us at ctac.ca. And what I'm going to do now is provide you with that link to give feedback. So in order to access that feedback mechanism, I invite you to click on the text in that box and then on Browse To. That's going to take you externally to a SurveyMonkey. And I'm also, I commit to sending the link to the SurveyMonkey to email or by email to each of you as well. So again, thank you so much for participating. For those of you we will be seeing at the Treatment Access Conference on Monday the 16th and Tuesday the 17th, look forward to seeing you there and look forward to seeing each of you on future webinars.